Third and final talk is from Theresa Marteau from the Behaviour and Health Research Unit at the Institute of Public Health. And she's talking about changing behaviour in populations.
Thanks very much. The Behaviour and Health Research Unit was set up just 2 years ago, funded by the Department of Health as a policy research unit. And the aim of the work in the unit is to develop, synthesize, generate effective ways of changing behaviour across populations. Governments and others in authority frequently try to change our behaviour, from trying to encourage us to tidy up, encourage us to have fewer children, encourage us to be slightly more careful when we cross the road, encouraging us to be more careful when we drive, and increasingly encouraging us to save energy and water in order to save our planet. Over the last 10 years, there's an increasing focus on the huge and growing global health problem, which until recently was mainly thought of as a problem focused in high-income countries. But it's now clear, recent estimates, that 63% of deaths worldwide due to 4 sets of diseases: cancer, cardiovascular disease, diabetes and respiratory disease. And the key causes are 4 behaviours: smoking, consumption of alcohol, overconsumption of calories, and overconsumption of sedentary behaviour. WHO recently estimated that if one eliminated those risk factors, changed those behaviours, then it would make an enormous impact on reducing diabetes by 75%, cancer by 40%. And critically, something we haven't talked about very much today, it would also reduce health inequalities by an estimated 50%, because a lot of these behaviours are socially patterned. In May of last year, WHO pledged to reduce non-communicable diseases by 25%, yet to have an action plan, but behaviour and behaviour change looks like it's got to be centre stage. There's a growing consensus amongst brain and behavioural scientists that behaviour is shaped by 2 parallel but interacting sets of processes, and various names are given depending on who the theorists are. Sometimes they're called slow and fast systems, sometimes conscious, non-conscious processes, goal-directed, habitual processes, reflective and automatic. And they're overlapping concepts. And many of the interventions that have attempted to change people's behaviour over the last 100 years have focused on reflective processes. So to give you an example, health education classically over the last 100 years has focused on giving people reasons to change their behaviour, talking about the benefits of changing behaviour or the harms of not engaging in behaviour change. More recently, a more sophisticated way of trying to encourage people to change their behaviour, personalising the risk information through biomarker feedback. This is just one Cochrane review conducted by myself and colleagues, looking at the impact on behaviour of communicating to people their risks of developing disease based on their genotypes. You can't see this, but the important thing, as you will know, is to focus in on the diamonds, and the diamonds are not shifted to the right-hand side. So what we see is very interesting, compelling approaches to changing behaviour, but sadly not effective at changing behaviour in populations. So in Cambridge, we're focused very much on the other side of these dual process models, where in fact there's very compelling evidence that these shape much more of our behaviour. I wouldn't want to get into figures, but people talk about 90–95% of our behaviour is actually controlled by those processes. So the way in which it's largely untapped potential for changing behaviour. So what I want to do is just to give you a little bit of a flavour for some of the work in our unit, which is very much sort of crudely characterised as attempting to identify the stimuli in our environment that both cue unhealthy behaviour, with a view to trying to eradicate those, and those that might cue healthier behaviours. working singly and together, often without people's awareness. So the three sets of methods that we're using are those of evidence synthesis, secondary data analysis using large data sets, and finally experiments, lab-based experiments, sort of proof of concept. So like Emily, I stuck to 8 slides, and so what I've done is I've jammed a whole load of stuff onto the slide. So I'm not expecting you to be able to read this, but I just want to say a tiny little bit about research under each of those headings, again to give you a flavour for the kinds of approaches and studies that we do with a view to reaching out, as it were, to others across in other schools who may, for whom there may be some echoes. So in terms of evidence synthesis, we've recently completed a large-scale scaping study of choice architecture. So these are ideas that come from that popular book, Nudge, about changing environments in order to change behavior. Very poorly defined terms, so this resulted in a literature review that had 800,000 abstracts that fell within our purview. So using text mining software, we were able to drill down and find 346 studies that met the criteria. And this gives you some pictures of the kinds of interventions that we found in the database for stimuli in the environment that shape behavior. So we already talked about design of furniture, design of offices, as well as availability, ease of access to different foods and alcohol. And on the very bottom, again, coming back to design, the shape and size in which food, alcohol and tobacco products are sold and presented to people. It's on that bottom line that we're now going into evidence synthesis with meta-analysis to look at how the shape and design of products, particularly their size, influences what we consume, which with the attendant effects on our behavior. In terms of secondary data analysis, we bought a very large data set. Well, we thought it was large, but people in big data tell me it's small, which comprises data on 200,000 trolley journeys around one particular supermarket. And what we were interested in being able to look at in the first small study was to estimate what the effect size is of putting things at the ends of aisles. Now, everybody thinks that the marketing men know the answer. Well, actually, they don't. They can tell you how much you might shift Coca-Cola versus Pepsi-Cola, but not at the level of detail that we want. So in our first study, what we looked at is what the increase in sales are from putting different drinks, so we looked at beer, wine, spirits, and fizzy drinks on the end of an aisle, while controlling for the price promotion that was on the product and the amount of space on shelf on which it was exposed in the rest of the store. So you can, what this shows is the percentage increase just from an effect of being on an aisle end. So 20% more sales of beer, going up to 50% for fizzy drinks. And the only point to make here is the effect on alcohol here is much larger than the effect that's modelled for minimum unit price, which the government might or might not be thinking about, who knows. But anyway, these are very large effects. So that's just an example of looking at one aspect of environment and trying to model what those effects are. In terms of lab-based experiments, we've been particularly interested in how stimuli in our environment can influence our behavior, as I say, without awareness. So advertising on TV is pretty good at doing that, particularly priming us to behave in unhealthy ways. So what we were interested in was the extent to which we could prime healthier eating. So we know that the majority of people want to eat in a more healthy fashion, but it's just that there often aren't the stimuli in the environment to make that an accessible goal. So in this particular proof of principle experiment, half the people were asked to rate some imaginary advertisements, and then there were filler tasks, and then they were asked to select from a range of snacks what they would like to eat, either fruit or non-fruit, less healthy snacks. And I realise this is a little complex without giving much detail, but what we found was that half of those who've been exposed to the prime, so that's in the red bars, when asked to choose between a fruit or a less healthy snack, when they weren't hungry, they were as likely to choose the fruit. So the majority of people are choosing fruit. But when they're hungry, so when they're biologically driven to choose something that may not be quite so healthy, the prime actually protects against going for the less healthy food. So, as I say, this is just a proof of principle. We're going on to do other experiments to see how that can be applied. So that's just, as I say, to give you a snapshot of the kinds of studies that we've been doing. So to conclude, this is an area where the evidence base is is weak, I would say. Nonetheless, I think it's fairly true to say that we do know quite a lot about how not to go about changing behaviour in populations. So there's quite a lot of evidence that tells us targeting reflective processes, trying to persuade people, actually is not going to, let's say, cut the mustard. The scientific task now is to try to identify what it is in our environments that's cueing healthier as well as less healthy behaviours, and to be understanding how automatic processes are working to influence our behaviour. As Rob has already said, achieving evidence-based policies requires more than just generating elegant evidence. And I think that we have a fantastic environment in Cambridge working with the Centre for Science and Policy, as well as Cambridge Public Policy, and this is an initiative that, just to remind the VC, that he launched, or part of this initiative was launched in London in November, which is the new Masters in Public Policy, which is starting at this university in October. So this university is very serious about public policy. But to return to the theme of today, given that changing behaviours in populations, I think is key to most, if not all, of the major challenges of the 21st century. And it is being addressed in different ways, as we already heard, by some of the different schools in the university. I really see this initiative as having a real opportunity of linking in those of us who are specifically focused on behaviour change, but finding others who are also wanting to engage in behaviour change outside of the health context. Thanks very much.